Hi, my name is Abdul and I'm presenting a case of hepatic infarction associated with ketoacidosis. This is a case report involving a 37-year-old man who presented to our hospital after 2 weeks of vomiting and diarrhea. He had a long history of diabetes that was poorly controlled, and prior to this admission, he had had prior admissions of diabetic ketoacidosis, with the most recent being a month ago. So he came to the emergency room and noted to be very hyperglycemic, noted to be acidotic, and hemoglobin A1C was 16.3. He presented with abdominal pain at that time and received a CT scan of his abdomen. Here on the CT scan, we can see some sort of vague hypodense lesions in the liver, indeterminate on this exam, and so we had recommended an MRI. On the MRI, we have axial and coronal T2 sequences, and here we can see some high signal intensity lesions in the liver that sort of correspond with what we had seen on the CT. On the pre-T1 sequences, these appear hypointense. And as we gave gadolinium, we can see some sort of poor delayed enhancement surrounding these lesions. And so this sort of brought about the diagnosis of non-occlusive hepatic infarcts. And as we can see from the other slides here, this is likely due to ketoacidosis and unrelated to hepatic artery or hepatic venous system. Here we can see on the arterial phase the hepatic artery, which appears patent. And here on the sort of portal venous phase, we can see that the portal vein appears patent as well. And so this likely pointed to ketoacidosis related infarction. Hepatic infarction is somewhat of a rare phenomenon due to the dual blood supply of the liver. The portal vein and hepatic artery, as well as collateral pathways, sort of protect the liver from ischemic insult. In the case of ketoacidosis, this can sort of increase the viscosity of the blood. There are a few other mechanisms by which can affect the supply of blood to the liver, including the release of epinephrine, norepinephrine, and these can lead to ischemia and infarction. In this case, this is likely related to ketoacidosis. The patient was managed conservatively and followed up after a month and was noted to be feeling better, was asymptomatic, and reported follow-up imaging that showed resolution of these lesions as well. This brings up sort of an important discussion because occasionally hepatic infarction can be treated with anticoagulants due to concern for sort of occlusive disease, but as we can see in this case, any sort of ketoacidosis related hepatic infarction can be treated conservatively.